So with me, I'd like to introduce my co-host. He's another leader who has been working tirelessly on our behalf in Washington, D.C. He is Mr. John Rother. He is the president and CEO of the National Coalition on Healthcare. He has over 80 member organizations that participate, and his job is to make sure that there is comprehensive quality of care. But prior to joining the National Coalition, he joined in 2011. He served as Executive Vice President for Policy, Strategy, and International Affairs at AARP. And in 2010, Mr. Rother received the Robert Ball Award for Outstanding Achievements for Lifetime Advocacy to Strengthen Social Security and Medicare. Please put your hands together for Mr. John Rother.
Okay, good morning, everyone. And I am very proud to be working with Leanna and her team at CalPERS, bringing together an outstanding group of presenters and also an outstanding audience. We look forward to a very productive day. I'm going to be brief. My job is to explain why we're here and basically to talk about the problem. And my hope is that all of the speakers who follow me are going to be able to talk about what we need to do about the problem. So a focus on solutions. So my first task is to say a little bit about who we are. The National Coalition on Healthcare is a long-standing coalition and probably the broadest coalition in Washington. About 90 different organizations are part of the coalition. And what unites us is a focus on affordability. In fact, I think we're the only coalition that's focused on healthcare affordability. And you can see some of our membership, providers, plans, consumers. It's basically everyone with the exception of the pharmaceuticals. And there's a common interest in a sustainable healthcare system. And that's what we're here to talk about today. How do we move forward in a way that's sustainable for cost of healthcare? The goals are laid out here. They're pretty straightforward. Leanna mentioned them as well. We want to make sure that we are talking about how to be creating a healthcare system that's efficient, markets that work, that prescription drug prices can be affordable and accessible, and especially how do we do a better job of coordinating the care for high-need patients, those patients who account for most of our healthcare spend. And then finally, what can we do to reduce the demand for healthcare through interventions around social determinants and things outside of the medical care system. All of these are component parts of what we need to talk about today. Now, 5 years ago, I was part of an Institute of Medicine study that looked at waste in healthcare. And it was a very thorough study, very comprehensive, evidence-based. And we concluded that about 30% of the healthcare dollar did not contribute to health outcomes. And you can call that waste. It was clearly 30% that we could identify as places to economize on that would not affect quality and outcomes from healthcare. Now, unfortunately, there is no one single bullet. It's a wide range of factors that drive healthcare costs, and it's going to require a wide range of solutions to address those. And so we hope that today we can talk on some of those, talk about some of those drivers of healthcare costs and what we can do to address them. Now we know that the national picture here is that healthcare costs have been fairly moderate actually in recent years, but are now projected to resume a pretty steep upward climb, taking more and more of our national economy. And that would be one thing if we were running an efficient system and producing great outcomes for everyone. But as I just mentioned, I don't think we're there. But what is the case already is that the money that we are spending on healthcare is squeezing out investments in education and infrastructure and housing, other things that actually do perhaps more to contribute to well-being throughout the lifespan. Now, we know in terms of immediate costs that there's been a big jump in what individuals and firms are paying for healthcare. Premiums are up quite substantially in the last 5 years, and it's also getting to the point now where I think people in jobs that are not that highly paid, it's not economical to provide health insurance because of the cost. So that's why the Affordable Care Act was there to subsidize people who are lower wage, who can't afford these kinds of premium costs. But again, if this continues, then we are going to be faced with an even more urgent problem. So we do have a problem already with access to care. And the Federal Reserve found that about a quarter of Americans report that they cannot afford care today. Now, most of these people have insurance. So they are having problems with deductibles and with other barriers to access. And more people, of course, are being covered by high deductible plans. So it raises the question, what good is insurance coverage if people can't afford to get care when they need it? Now in California, we're seeing a pretty dramatic increase in the cost of care. And we need to say that California is in better shape than much of the rest of the country. However, you're going to be faced with the same trade-offs and the same challenges that are true nationally. Just looking at Medi-Cal spending, we can see that there's a pretty steep increase, most of it covered by the federal government. But as we all know, there are proposals in the Congress to cap that, to cut it back. And there, again, the question is this sustainable? How much further can we go with this kind of trend? Finally, we know that one of the leading causes of increased costs is specialty drugs. This is a chart that focuses on the very expensive drugs that cost more than $600 per prescription. And you can see the climb is very dramatic and probably will continue to be dramatic in the era of more and more focus on expensive drugs. And the question is, do these displace other healthcare costs, or are they simply additive, adding to the overall picture? When we look at the increase again at the state level in terms of drug spending, we see a pretty big jump, especially for Medi-Cal, but also prisons. And of course, a lot of this is related to the cost of Sovaldi and therapies for Hep C, very expensive, with a huge number of people potentially appropriate for therapy. And then finally, we see increases in total costs for retiree benefits, again, on pretty much an unsustainable path. But here's the pattern that I want to especially call attention to. For several years, perhaps as a result of the recession in 2008, there was a very moderate level of increase, perhaps a surprise. But now we're back on the high rise. We're back on the escalator in terms of year-to-year increases. And while we may have gotten a little breathing space because of the experience following the recession, it's clear that now we're going to be challenged once again to address what's behind these costs, whether they're generating value, and how do we achieve a sustainable system. So one last graphic, and that has to do with the 5% of patients who account for half of total spending, those with multiple chronic conditions. And the thing I want to point to is the graphic on the right side. The number of people with 3 or more chronic diseases has been exploding. And the projection is that this will explode almost 3 times by the time we hit 2030. So what is that? Is that, it's partly demographic, but not all. A lot of it is behavioral. What is it that results in people having 3 or more chronic conditions and then generating such a high need for treatment and healthcare costs? So again, we don't have any one silver bullet that we're likely to find that addresses all of these issues. Instead, if we look at the individual drivers of health costs, perhaps we can identify individual strategies to address each. And taking together, perhaps we can put together a menu of potential changes to policy and practice that can keep healthcare sustainable. So here are the issues that I hope we can address the rest of the day. What actually drives the demand for care? What are the costs of inputs? What about delivery system coordination and efficiency? The structure and competitive dynamics of markets for healthcare. The structure and competitive dynamics of the markets for health insurance. The incentives for employers and employees. And cost-sharing practices and patterns. So if we're lucky today, by the end of the day, we will have some ideas for each of these. And it's my hope and my commitment as head of the National Coalition on Healthcare that we will take these ideas back to Washington and we will do everything we know how to do to inject them into a debate that so far has notably been lacking in serious efforts to deal with cost.